we'll give about 5 minutes and then we'll go ahead and get started. Okay, or can everybody hear me okay? Okay.
Yes.
Alrighty, perfect. Okay, so while we're waiting just a couple more minutes for everybody to come in. So my only 20 questions with this one. I know the last two like Q&A type ones that I've done have been really long. So I tried to cut back on, and my approach this time is not so much to like be as comprehensive as the other ones were, but more so I picked questions that kind of hit some of the like harder topics, or at least topics that I thought were harder or a little bit confusing, or that are like common points where a lot of people get tripped up on, because it can be fairly easy to, you know, make a diagnosis of, oh, that's bipolar 1, that's whatever. But I tried to pinpoint some of the things that are a bit more difficult and more of a point for confusion. So only 20 questions, and these are like more, because there's some of the more tricky things, they're going to be more difficult. So if you're, you know, if you miss some of them or whatever, don't be discouraged. The test will definitely be much easier than these questions, and in BME there'll be some questions like these, but also too. So okay, one more minute to see if anybody else pops in. But and I mentioned last time, but on this NBME, I didn't include any questions on it, but they like to throw in some like healthcare systems type stuff, like more of like P3 almost type stuff. Like, I don't know, maybe somewhere like maybe around 5 or so questions pertaining to that. So if you have extra time and you want to study that and you feel that that's something that would benefit you, then you can, but or you can just, you know, do your best on those and see what happens. So you're not going to lose a ton of points from those. Okay, alrighty, so we'll go ahead and we'll get started. Let's see, share my screen. All right. Y'all can all see my screen here?
Yep.
Okay, perfect. All righty, then here we go. We'll go ahead. There's your first question. And I'll throw out a poll again, just like last time. Okay, give you all about 10 more seconds there. Okay, I'm gonna call it. So y'all did really good on this one. Let's see, I'll share the, so yes, so this gentleman has neuroleptic malignant syndrome. So one of the neuroleptic malignant syndrome is one of the several adverse effects that can occur when you're taking an antipsychotic medication. In this case, he's taking risperidone. And so one of the kind of most difficult things to differentiate NMS from is going to be serotonin syndrome. But there's, because they can present very similarly. You can have a fever with both of them, delirium, but one of the things that's, autonomic instability is another one that you can have with both of them. So that means you can either have hypertension or hypotension, tachycardia or bradycardia. But one of the things that differentiates them is that with neuroleptic malignant syndrome, it's going to be mainly just generalized stiffness is going to be what's the prominent feature. Whereas with serotonin syndrome, you're going to have hyperreflexia is going to be kind of the trigger word for that. Also with serotonin syndrome, you'll probably have some more like physical manifestations. So you might have like pupils may be dilated, you may have sweating, you may have tremors or fasciculations. Those types of things are going to be more serotonin syndrome. And then also you kind of look at the context of it. So given the patient's history here, citalopram just by itself, although it is an SSRI, SSRIs by themselves are not really as likely to cause serotonin syndrome. It's mainly when you start combining SSRIs or when you are taking them with an MAOI, a monoamine oxidase inhibitor. So let's see, did some of y'all, so some of y'all did put serotonin syndrome. So phenelzine right here, that is an MAOI, but why would this really not put the patient at risk for serotonin syndrome? Why is this patient not really at risk?
Because he stopped 3 weeks ago.
Yeah, and so what's the normal washout period that you need for an MAOI?
2 weeks.
Yep, 2 weeks. Yep, exactly. Yes. So yeah, so that's why this patient really isn't at risk for that. Let's see if there is anything else. So what would be the treatment then? What would you do for a patient who has NMS? What's the very first thing that you'll do?
Stop the medications he's on?
Yes, exactly. Stop the offending medication. So stop the antipsychotic. You can also, in some instances, you can get NMS if you discontinue a dopamine agonist. So like say a Parkinson patient, if you're giving like pramipexole or something and you stop that, you can also precipitate NMS. So in that case, you would then restart that medication. But yeah, exactly. And then if it, and so somebody put it in the chat, if it's really refractory, then you can either give dantrolene or you can give bromocriptine. What's bromocriptine's mechanism of action? Yeah, it's a dopamine agonist. Yep, that's right. So so dopamine agonist would be why we're giving the bromocriptine. And then dantrolene, why are we giving dantrolene? Why would that be important? So one of the dangers with NMS is that because you have this generalized muscle stiffness and this like contraction that's happening everywhere, you're at risk for overheating, same as you would with malignant hyperthermia, and also you're at risk for rhabdomyolysis. So dantrolene, remember, acts on those the calcium channels there and within the muscle cells, and so that's why we're giving that one, is to prevent the muscle breakdown and also the overheating. Okay, let me see. Was there anything else with that one that I wanted to make sure to mention?
This may be looking too far into it, but for the atypical antipsychotics, they have a role on the serotonin, on increasing serotonin as well as inhibiting dopamine, right?
Yes, that's exactly right. And that is fair game for your test. I believe it's serotonin A, I believe is the receptor.
Yeah, 5H2A.
Yes.
Is it realistic for them being on an SSRI with an atypical antipsychotic to develop serotonin syndrome? I guess is what I was going to ask.
Ah, I see.
Because of that?
I've never heard of that. I'm not going to say it can't happen because I don't know enough to definitively tell you that it can't, but I have never seen any question geared towards that or anything.
Yeah, I'm sure they'll definitely clarify it with like the no hyperreflexia or something, or the no myoclonus or something like that. But I was just curious if that ever did come up, if that was a possibility. But yeah,
I see your point.
Too far into it.
Yeah, I see your point, but I don't think so. I think because it's specific to only that one receptor, I think is why they wouldn't really be at risk. So yeah, sorry, I don't have a better answer for you there.
No worries.
Okay. Oh, and so another important thing with NMS, what might you find on laboratory results?
Creatine kinase.
Yeah, increased creatine kinase from the muscle breakdown, the rhabdomyolysis. And then what's another thing that you might find? This one is a little more less intuitive. So you can find a neutrophilia. So you'll have so a leukocytosis. So your neutrophil counts will be up in like the 80 percentile is another thing that you can look for to help differentiate it. And usually if it happens, it's going to be right after you start the antipsychotic. It can happen at any time, but usually it's going to be particularly right after, like within 1 to 3 days, kind of a gradual onset. Okay. Yeah, I think that's all I wanted to say on that. And so on this first question, because I don't have any more questions about side effects from different antipsychotic drugs, but I do want to take a little bit of time, and I won't do this on every question. I just want to do this on this question. I do want to take a little bit of time to talk about the other EPS effects. This isn't an EPS effect, but about the EPS effects of antipsychotics real quickly, because that is definitely fair game and it can sometimes be confusing. So acute dystonia, what is that one? Or a dystonic reaction?
Like muscle spasms?
Yeah, like a muscle spasm. Usually it's the neck. A lot of times it can be the eyes. They call it a gyro, like a gyrocentric crisis or something. But anyways, but their eyes get stuck looking up. It can be facial grimaces, things like that. So that's acute dystonia, and it can also be the tongue. And so with that one, you don't have to discontinue the antipsychotic. You might try to back off the dose first, but you don't actually have to discontinue it. What 2 drugs can you give for that one? So if you have muscles contracting, the neurotransmitter there is acetylcholine. So what would it make sense to give then, perhaps? So an anticholinergic, so you can give benztropine is usually what they give, or diphenhydramine, because although that's an antihistamine, it does have anticholinergic properties as well. So you, if you can switch to another antipsychotic, you can do that. Or if discontinuing is feasible, you can do that, or reducing the dose. But if not, then it is safe to continue it and either give benztropine or diphenhydramine. So another EPS is Akashesia. What is that one?
Like restlessness?
Yeah, so it's like this urge to like get up and move. They might shake their arms or something because they're just so like they can't sit still. We had a patient who did that. So yeah, so yes, exactly. Subjective restlessness. And so with this one, you again, if it's feasible to switch, discontinue, or reduce the dose, you can do that. But if not, you can give. What can you give for this one? There's 3 different drugs, or 3 different classes of drugs. Yes, a beta blocker, you can give that one. Good, because beta blocker kind of stops, kind of calms down the symptoms. It's symptomatic control. Yep, so that's typically propranolol is what they'll give. What's another one you can give?
Those?
Yep, a benzo, because it calms them down. So a lot of times lorazepam is what they'll give, so a benzo. And then what's the last one? It's one of the ones that you also use for acute dystonia.
Would be benztropine again?
Yep, benztropine. Yep, benztropine you can pretty much give for all the EPS effects except for tardive dyskinesia. So the next one, Parkinsonism, drug-induced Parkinsonism. That one is kind of straightforward. So you can have a resting tremor, rigidity, flat affect, bradykinesia, all that stuff, shuffling gait. And what can we give for that one? I just told you that benztropine is one of the things we can give. And what's another one? What would make sense to give? How would you normally treat Parkinsonism?
Dopamine agonists?
Yep, dopamine agonist. So typically the one they'll give is amantadine. Yep. Okay, and then with tardive dyskinesia, what is that one? This one was always one that kind of confused me. Yeah, so like tongue protrusions, yeah. So they might do like a type movement, any kind of like a repetitive kind of facial type tick looking thing. And so this one is different from the other 3. The acute dystonia, the akathisia, the Parkinsonism, all those can pretty much develop at any time throughout the course of treatment. Typically, it's going to be more likely right after you start it than later down the road, but it can occur at any time. With tardive dyskinesia, it usually takes several months. So like about 6 months after is usually when you'll see it start popping up. And with this one, you want to discontinue the medication because this one can have a lasting effect. The other three, as soon as you stop the medication, it goes away. But with tardive dyskinesia, it can stay and it'll continue to worsen the longer you give the medication. And the longer you give the medication, the less likely it is that it'll go away once you discontinue. So you want to discontinue with TD. And then, and by the way, it can also be, it doesn't have to be the face or whatever. It can also be like the trunk, the extremities. But typically, if they give it to you, it'll probably be the face. But, and then with this one, does anybody know what you would give for this one? So you would give either valbenazine or do tetrabenazine. So the benazine class is it's a VMAT inhibitor. So it's a vesicular monoamine transporter inhibitor. So basically, it kind of works like reserpine, and it depletes the neurotransmitters from the terminal. So okay, alrighty. And then one last thing that I want to mention on this one, and I promise this is a long question. All of them will not be this long. I just wanted to, those were, maybe y'all know them well, but I had trouble with them. So on this one, serotonin syndrome can also, in addition to being precipitated by SSRIs given with an MAOI or doubling up on an SNRI, in addition to those, you can also have them with TCAs, tricyclic antidepressants, and you can also have serotonin syndrome with tramadol and also meperidine. But tramadol is one they like to throw in there because tramadol, although it's technically like a atypical type opioid, it also hits some of the serotonin receptors. It has some serotonergic activity. So you might see it in a patient who has like some kind of, chronic pain issue that they're taking tramadol for with an SSRI. And also MDMA. So ecstasy will also do it, and because it's in addition to being an agonist at the NMDA receptors, it also hits some serotonin receptors. And linezolid, the antibiotic linezolid, is another one. So those are just some other things to look out for. And what do you give to treat serotonin syndrome besides obviously discontinuing medications?
Cyproheptadine.
Cyproheptadine, yeah, and that's a serotonin antagonist. So, okay, alrighty. I think I've beat that dead horse. We're done with that. Okay. Number 2. Okay, give you a few more seconds on this one. Alrighty. So this one we had some trouble with. So what is going on with this patient here? What does she have right now, and what's her diagnosis overall?
Would be bipolar 1 with a depressive episode.
Yes, exactly. So she's a bipolar 1 patient, currently in a depressive episode. So what does that automatically rule out as far as pharmacological treatment of her depression?
SSRIs.
Yeah, and actually any kind of antidepressant in general should be ruled out, because all of those can do what to a bipolar patient?
Induce mania.
Exactly. So bupropion would be ruled out, citalopram, imipramine. Imipramine is a what?
TCA.
TCA, yep. And bupropion, what's that one's mechanism of action?
Doesn't it affect the norepinephrine and dopamine transporters?
Exactly. Yep. So it inhibits reuptake of norepinephrine and dopamine. Good. And citalopram, we said, was an SSRI, and that also rules out venlafaxine, because venlafaxine is a what?
SNRI.
Yep, SNRI. Good. So that leaves us with haloperidol and quetiapine. And so haloperidol is a what?
It's an antipsychotic.
Yes. Which generation?
It's a typical.
Yes. So first generation. Yep. Good. Typical first generation. And quetiapine is a what?
Atypical second generation.
Yes, exactly. So second generation antipsychotics can actually be used in some instances. Wait, what did I just? I don't know why I put that as the. Well, I don't know why I put bupropion as the right answer. It's quetiapine. I'm sorry, that's stupid. Quetiapine is the right answer. Yeah, let me fix that. Yeah, so quetiapine would be the right answer. So the point of this question is that in bipolar patients, as y'all correctly identified, you don't want to give them any kind of antidepressant or SSRI. What you use for the treatment of depression in a bipolar patient is you're either going to use quetiapine, or you're going to use lurasidone, which is another second generation antipsychotic, or you're going to use lamotrigine, which is an anticonvulsant and mood stabilizer. But all three of those are effective in the treatment of depression in a bipolar patient. And then you can, in some instances, so if you have them stabilized on a mood stabilizer, so on lithium or valproate, then you can add on an antidepressant like an SSRI at a later time once they're stabilized. But this patient is not taking anything, so we would not want to put her on that to start out. We would want to give her either lithium or valproate, and we'd also want to treat her depression with quetiapine, lurasidone, or lamotrigine. Yes. Any questions on this one or the one before? Nope. Sorry, I don't know why that was on the wrong answer. Okay, next question. Give you a few more seconds here. Okay. So again, this one was another tricky one. So first line treatment for ADHD in children and adults is what? So yeah, so stimulants are going to be the first line treatment. Yes, so amphetamine, methamphetamine, dexmethamphetamine, all of those things, or any kind of stimulant is going to be first line treatment. However, if you have a patient who either A, prefers a non-stimulant because of whatever reason, or if you have a patient who has a history of addictive behavior, and that can be a personal history of addictive behavior. So in this case, is I believe cocaine and alcohol abuse, or it can be family history. Even if the patient doesn't have any himself, if they have an extensive family history of alcohol, substance abuse, then amphetamines are going to be, for the purposes of your questions that are asked on the MBME and STEP and whatever, are going to be contraindicated in a patient with any kind of history of abuse, of substance abuse. Also, it'll be contraindicated in patients who have a history of seizures, a personal history of seizures, or if they have any kind of cardiac problem, because obviously amphetamines are going to decrease the seizure threshold as well as have effects on the cardiovascular system. So they'll stress the heart. So methylphenidate would normally be the correct answer, but because of this patient's personal and family history of abuse, it won't be in this patient. So what is the next best thing that we could give a patient for their ADHD, an adult patient? So atomoxetine is going to be the one here. So atomoxetine, what's the mechanism of action on that one? Yes, well, almost. So it's a norepinephrine reuptake, and that's what you meant by the T. Okay, yeah, so it's a norepinephrine reuptake inhibitor. So it still has the same effect, although not quite as effective as a stimulant, but it's non-addicting. So that's what we would give for an adult patient. So first line, stimulants, second line, atomoxetine. Third line, if we even have to go that far, which I doubt a question would ask you to, but it would be like a TCA or bupropion, because remember, bupropion has the dopamine and norepinephrine effects. Okay, so clonidine is one that you can use for ADHD, but in what population? So clonidine and guanfacine, both of those are going to be used as second line treatments in children. So in children, first line is stimulants and second line is going to be clonidine and guanfacine. So certainly CBT would be helpful, but would it be the primary treatment? Disipramine, that's a what? Disipramine. Yep, it's a TCA. So that would be like a third line treatment. And then modafinil, does anybody know what that one does? That one's used to treat narcolepsy. It hits a lot of different receptors. Okay. Next question. Did anybody have any questions on that one? Give you a few more seconds. Okay. So y'all actually did really good on this one. Did they talk, a different guy gave y'all's childhood disorders lecture than who gave it to us. Did y'all talk about this one? Reactive attachment disorder?
I think
Yes.
briefly.
Briefly? Okay. Yeah. Okay. So this one is a bit of a hard one to recognize because it has features of a lot of different other issues. So it's primarily going to be in a child who has had a kind of, I guess for lack of a better word, a traumatic upbringing. So they either were frequently passed from caregiver to caregiver, they were institutionalized, like in some kind of orphanage or something for a prolonged period of time. They suffered abuse, they suffered neglect, something like that. And and what's going to happen is basically they're going to be withdrawn socially. They're not going to seek comfort and they're not going to respond to it. So that's why she's not responding to the mother's attempts to, hold her, comfort her. They will typically they lack positive emotions and they'll just they'll have like a crying fit and irritability in response to a non-threatening situation. All those things are going to be typical of reactive attachment disorder. She is on development otherwise, so there's no delay in any of hitting any of her milestones. Let's see, and then the hoarding behavior there that she has, that's typical of children who have suffered abuse or neglect. It's kind of a adaptive response. If you don't know when your next meal is going to be or whatever, then you hoard food. Okay, so the other thing, so there's kind of two different kind of opposite ends of the spectrum that can result from a child with abuse, neglect, prolonged institutionalization, that sort of thing. So one of them is a reactive attachment disorder, and then there's kind of a polar opposite of that. Which one would that be?
Disruptive social engagement disorder.
Yeah, disinhibited social engagement disorder. And that one's the exact opposite, where they're just super friendly. Everybody's their friend. They're just trusting of everybody, which can be also dangerous as well. So, and of course, things like ADHD, all those types of things are going to be associated with, a traumatic or difficult childhood. All those things can come along with this and might be comorbid with some of these as well. Okay. So I did want to talk about, this is my only question I think I have about childhood development. So I did want to just talk briefly about, another one that, did y'all talk about Tourette's?
I don't think so.
Okay, so I just want to mention Tourette's briefly. You don't have to be an expert in Tourette's, but there's a couple questions about it on my NBME, and you'll for sure see questions on STEP about it. So Tourette's, in order to have Tourette's, you have to have at least one verbal and at least one motor tic symptom. You have to have both of them. If you only have one or the other, then it's just a verbal tic disorder or a motor tic disorder. But if you have at least one of both, and they don't have to be present at the same time, they can come and go, and they can change, and I think it's like 6 months or something, but they won't make you determine a time frame on it for the purpose of your questions. But if you have both of them, then they qualify for Tourette's. And Tourette's can also be, a lot of times you'll see it precipitated. It's kind of unclear as to whether it's just uncovered or whether it's actually caused by, but children treated with for what disorder will a lot of times then go on to develop a tic disorder of some sort after they begin treatment. So ADHD, because we just said that we treat it with stimulants, and so stimulants increase the likelihood of developing a tic disorder of some sort. So that's something that you might see on a question. If not on the NBME, you'll likely see something related to Tourette's on step 1. It's also commonly comorbid with OCD, Tourette's is. Another thing, so talking about autism. So with autism, it can be a symptom of another constellation of different symptoms of some disease, or it can be a standalone. So it can be an autism spectrum disorder. And then there can also be different types of autism with a specific name. So some features of autism that are distinguishing are obviously the difficulty in social interaction. So a lot of times that'll be manifested by a lack of eye contact. It'll be a lot of times they'll interrupt the physician, and what they're saying is not going to pertain to the topic at hand. So they might interrupt the physician to continually talk about different breeds of horses, which is also a clue to another feature of autism, which is a restricted, like a restrictive, intense obsession or interest in something. So it can be an interest with horses, it can be an interest with outer space, it can be whatever. That's another quality of it. Also, stereotypies or stereotypical behaviors. So it can be like hand flapping, or it can be just some kind of movement with their hands. So it's not a purposeful movement, but it's more than just like a, I guess a tick, you would say. It's a semi-purposeful movement. We call those stereotypies. Let's see. Okay, but some specific types of autism that you should know are going to be some of the genetic types. So one of them that's they like to ask about is Rhett Syndrome. And Rhett Syndrome, it's primarily little girls, and it is, they'll have a hand wringing will be something that they describe. And around like 18 months or so is when they'll have normal development up till that point, and then they could have some regression, or they could just stagnate at that point. But that's one that they like to test on. Okay. Another one, Fragile X, you should probably be familiar with. That's the long face. It's X-linked. And you'll have the hypergonadism, so large testicles, long face, also mental retardation to a varying degree. Fetal alcohol syndrome can present with that. Something you want to know about that one is the smooth philtrum and small head. So, okay, I think I've talked enough about that. I've worn that one out. Next question. Okay, give you a few more seconds. Okay. So y'all did really good on this one. So she does have ODD. oppositional defiant disorder. And so this one can be difficult to differentiate from a few things. You want to be able to differentiate it from conduct disorder, from normal adolescent behavior, and also from depression. So ODD, the way that it's differentiated from conduct disorder, a few of y'all went for that one. So with ODD, they don't really technically break any laws per se. They might do things that are considered socially unacceptable, or that would be considered, like rude or mean spirited or whatever, but they're not going to really be out raping people or stealing things or, hurting animals. And it's primarily going to be directed at authority figures. So they're not really going to have problems with other students. They're not going to have problems with, siblings. They're not going to have problems with people who are not in authority over them. So that's one way to differentiate from that. And then with conduct disorder, also another clue that they'll give you a lot of times will be that they'll say that he expresses no remorse, or he laughs about it when he talks about how he, skipped school or, hurt an animal or whatever, right? So that's how you differentiate those two. And conduct disorder, a lot of times will go on to become what in an adult?
Antisocial.
Yeah, antisocial. And then, so to differentiate from normal adolescent behavior, anytime that it says that they're failing classes or they're struggling with their grades or something, that's your clue to you that this is not normal behavior. In real life, that could be the case, but for the purpose of questions, if a patient is failing classes or doing poorly in school, they say anything like that, or that they're having trouble making friends, whatever, all of that is your question clue that the answer is not normal behavior or normal development, okay? Then let's see. And then to differentiate from depression, it's because depression a lot of times in adolescents, yes, I can, Stephen. So, but depression first. So in adolescence, it can present with irritability a lot. And so, but that would be more of a generalized, you would see it interacting with peers, interacting with siblings, interacting with friends, not just authority figures. Okay, so intermittent explosive disorder, that one, I don't know, for us, I felt like they didn't really cover it very much in lecture. I don't know, y'all have different people giving those lectures than we did, so maybe they hit on it. But so with this one, that's basically kind of like an anger management problem. And it can be diagnosed in children above, I want to say it's like the age of 6 or so, because basically you want them past the age where it's normal to have temper tantrums. Yeah, that's the thing. Yeah, they'll put it on a lot of answer choices. And so it's easier, to get to the right answer if you know what the wrong answers are. So, so with intermittent explosive disorder, it can be diagnosed in a child greater than, I think, 6. It can also be diagnosed in adults. And basically with that one, they're basically normal functioning, except they'll have episodes where they get really angry and they throw a fit, or they yell at someone, or they might even become physically abusive or whatever, but it's only in that isolated event. And a lot of times afterwards, you'll even say but they expressed remorse or whatever. That's kind of a clue to you that it's not conduct disorder or something like that. They may not give you that, but a lot of times they'll say after the events that they expressed remorse for doing it. And they don't have an irritable mood or anything, usually in between. It's just irritable mood would be more associated with oppositional defiant disorder. It's just kind of these isolated events of just extreme anger. Was that good? Yeah, no problem. Any other questions on this one? Okay, I'll pull up the next one. Oh, and sorry, one other thing that I wanted to say about childhood disorders. So if you have a child that just has a problem with language, like let's say that they come to the office and they're just like they're just not expressing themselves well, but like they let's say they may have a good eye contact and they don't have any like of the restricted interest or anything like that characteristic of autism, that's going to be a language disorder. But they'll make a point to say that they don't have all these other symptoms of autism. They'll make a point to say no restricted interests, no stereotypical movements, that sort of thing. And they might try to throw you off with a language disorder by saying that the kid will have tantrums when he can't be understood, but that wouldn't be grounds for like ODD or intermittent explosive disorder. That would still be a language disorder. It's just that the kid's reaction to not being able to express himself or be understood is to get upset and throw a fit because he can't express himself any other way. So that's something that they like to throw in there. Give you a few more seconds in this one. Okay, so yeah, y'all did really good on this one too. So lithium is going to be, so the correct answer here. So he is a, let's see, did I tell you that he is a bipolar patient? No, I don't think I did. But okay, yes. So anytime you have a tremor, those are, that's primarily cluing you into, yeah, it's probably going to be like lithium or valproate. You can have it with some of the antipsychotics. But so with this patient, let's see, also the vomiting and the ataxia, so the difficulty walking in a straight line, all those are going to be hinting towards lithium. And lithium is the one mood stabilizer that can induce seizures, because all the other mood stabilizers like valproate, lamotrigine, those are all anti-seizure medications. So if it says that the patient has a seizure, you can pretty much rule those out because it's their job to not let people have seizures, right? Okay, and then with lithium, there's kind of two different types of toxicity. There's acute, which is more of the GI symptoms like nausea, vomiting, diarrhea, and then there's there's chronic toxicity, which is if they're out of like the therapeutic range for a long time, or even if they're in the therapeutic range for a long time, but they've been taking it for many, many years. It can also be precipitated by certain drugs. So in this case, the hydrochlorothiazide that he prescribed, the diuretic, likely caused the man to have some dehydration. And because lithium is solely excreted by the what?
Kidney.
Yep, by the kidneys, the dehydration decreased the perfusion of the kidneys and thus decreased the GFR. So basically the end result is that his lithium was not getting spit out like it normally does, so he probably is above the therapeutic range, which caused all these symptoms. Some other things that can induce decompensation or that can induce lithium toxicity in a patient who is previously stable, in addition to diuretics, are also going to be ACE inhibitors, NSAIDs, all of those, if you remember back to MOS, they decrease renal perfusion. Also, some things that are nephrotoxic, like tetracyclines, can have some problems there. Metronidazole can also induce it. Well, so lithium is a really dirty drug. What else can lithium cause besides what we see here? So obviously there's the neurologic symptoms that we call it a metallic tremor that they have. We also talked about the ataxia. They can have fasciculations, seizures like this person has, delirium, agitation, but what other symptoms can there be? Nephrogenic, yep. So nephrogenic diabetes insipidus, that is correct. So you'll have a patient eating more, or I'm sorry, drinking more, peeing more, correct? What else? Oh, yep, somebody said hypothyroid. Yep, so they're thyrotoxic. What else? What other organ can they hit?
Parathyroid.
Yeah, parathyroid, yes, and also, yes, so they are cardiotoxic, and they also do have a congenital cardiac condition that they can induce. And what is that congenital heart condition? Yes, Ebstein with a B, not the P, but yes, Ebstein. Yeah, no, you're good. No, you're good. You're good. I mean, that would get you close enough to the correct answer on a test anyhow. But yeah, Ebstein anomaly, and basically what that is you have atrialization of the right ventricle. So you have like this huge right atrium and a little bitty tiny right ventricle. So that can happen to babies if their moms are taking lithium. And then yes, Chelsea, you said the hyperparathyroidism. So a patient could come in with like a crazy high calcium, like 13 or something, and that could be indicative of lithium toxicity there. Yes. With valproate, so valproic acid, what organ is that particularly? That can cause a tremor as well, but what organ is it particularly going to be toxic to? No, so valproic acid is going to hit the liver. The liver is going to, so you'll see some elevated LFTs, could see some elevated bilirubin or GGT. Yeah, so that's going to be, so the liver is primarily what valproic acid is going to hit, which you can get a hepatic encephalopathy if it's progressed to a point where, yes, it also, yes, you can also get some pancreatitis. Liver is probably going to be the one that's primarily affected, but you can get pancreatitis as well. Good. And you can also have some GI symptoms. So lamotrigine, what is that one? What's the side effect? The main side effect associated with that one? Some of the antibiotics cause as well. Yes, Stevens-Johnson. So the big blisters or a red rash. Yes, so that's lamotrigine. And now of all the mood stabilizers, let's say that you wanted to, a pregnant woman with bipolar disorder, you want to treat her. Which of them are you going to give to a pregnant woman? So obviously not the lithium. And valproic acid depletes what? Depletes folate, yep. So lamotrigine is what you're going to give a pregnant woman with bipolar disorder. That's the one that's safe in pregnancy. So if a pregnant woman with bipolar needs treatment, that's going to be the right answer on the test. Let's see. Okay, and then just real quickly, some other important toxicities for drugs. So clozapine, what's that? That is a what, first off? Yep, second generation antipsychotic, so an atypical. And what is that going to cause? What do you have to check like every several weeks if you're giving that to a patient? And what is that? What can it cause? Agranulocytosis, exactly. So you have to do blood counts every couple of weeks. So that clozapine will pretty much never be the first line treatment for a patient. What is the indication for giving clozapine?
If other medications don't work.
Yeah, so refractory psychosis. So if they've tried at least 2 other medications and those medications failed either due to ineffectivity or side effects, then clozapine will be the one that you want to give. Yes, and second generation antipsychotics are also in general, but especially like olanzapine, what additional side effect do they carry because they hit the serotonin receptors? So metabolic syndrome and weight gain, yes. Yeah, so metabolic syndrome, weight gain, high lipids, diabetes, all those things can be induced with second generation antipsychotics, particularly olanzapine. So might want to caution, it's not necessarily a contraindication if you have an obese patient or a patient with diabetes or hypertension, but you might want to exercise caution in that. But that could be a fair game question. And then also risperidone. What special one does that have? What special side effect with risperidone, which is another second generation antipsychotic?
Is that the like hyperprolactinemia?
Yes, exactly. So that can manifest with gynecomastia in males. They could even have some nipple discharge. It could also manifest as decreased libido or other sexual side effects. So why does metabolic? So I cannot tell you exactly. I don't know the exact mechanism behind that, Stephen, but I do know that serotonin receptors are involved in your hunger drive and in like your basal metabolic rate, but I can't exactly tell you why. I apologize. And I don't think they'll ask you to make any sort of connection beyond that. So sorry. Okay. I think that was all. Oh, and then one thing that would be fair game, what system is inhibited? So obviously risperidone being a second generation antipsychotic, it's a dopamine antagonist, but what system is it antagonizing the dopamine in to cause hyperprolactinemia? Kind of pulling a little bit back from the neurology part of this block. Yeah, tubuloinfundibular. And to cause Parkinson's, what pathway are they inhibiting there? Nigrostriatal. Yep. Okay. Good. Okay. I think that's all I'm going to say. Yeah, I think so. Okay. Alrighty. Okay. Cool. And it's D2 that they're inhibiting to have their therapeutic effect of antipsychotic. Yeah, that's all I want to say. Okay. Alrighty, next question. Okay, give you a few more seconds. Okay. All right, yeah, you're like really good on this one. So this one, so yes, the point of this one is that benzos can be they can have the opposite effect of what they're intended to in elderly people. They can be particularly dangerous. Not only do they increase the risk of fall and things like that because of sedation, low blood pressure, that sort of thing, but also particularly in people who already have a little bit of cognitive impairment, which is normal with increased aging, right? You have a little bit of mental slowing, a little bit of memory loss, and all that's normal. And we say that those people have decreased cognitive reserve. Particularly in those people, it can precipitate agitation and confusion and whatnot. So you want to be careful with prescribing it to elderly patients. Another reason that's particularly harmful or dangerous in those patients is because they have older people have a decreased GFR, so it's not cleared from the system as efficiently as it normally would be. So decreased metabolism and excretion there. So and you wouldn't want to treat it with another, you never want to treat a condition that's drug induced with another drug. You want to first discontinue the drug and then look to treat it with something else. Donepezil, what's that?
An acetylcholinesterase inhibitor?
Yep, exactly. So that's used in the treatment of Alzheimer's, but that's not what this patient has. Yep, okay. Any questions on this one? And that's all I wanted to say on it. Okay. There we go. Okay, a few more seconds. Okay, so this one was a difficult one. The dementia questions can be some of the most difficult to get to the right answer on here. So a couple things to look for. So first off, this patient brought himself into the office. Why is that important? He wasn't brought in by family, he was brought in himself. Why is that important?
He recognizes the issue. He knows like his situation, where he works, why he's left, all of these things.
Exactly. So a patient who truly has dementia is most often going to be brought in by a family member or a friend or somebody who's concerned about them, because they are not going to have the cognitive wherewithal to be able to identify that there's a problem. They may be able to say, yeah, I feel more forgetful, but they can't explicitly tell you instances of when they were forgetful. Like, I forgot my keys the other day, or I can't concentrate to read a book. They're going to be more apathetic about it and less concerned than the people around them are. Someone who either just has normal aging, or who has cognitive impairment due to stress or dementia, which we would then call pseudo dementia. Not dementia, due to anxiety or depression, which we would then call pseudo dementia. They're going to be very aware of it, and they're going to be concerned by it, and they'll be able to give you specific instances of when they were concerned about it. So that's one thing there. Another thing is that his imaging was normal, so that also decreases the likelihood of some sort of dementia going on, right? We'll talk about the different types of dementia here in just a minute on a different question, but so we can talk about some of the changes that we would see on imaging with those. But so that's another thing there. And then also, so he has a lack of effort here. So poor testing effort, because on the different, he declines several exams and he says, I just can't do it. I just can't. So that can be a couple things that can, one, go along with depression, but also two, a patient who truly has dementia, a lot of times will, they'll kind of confabulate and give false answers. They won't necessarily be like, well, shoot, I just can't do it. They'll give you incorrect answers unintentionally. They'll give you incorrect answers and whatnot. So that's another instance that's kind of relating to the depression. So what you kind of have to do, oh, and another thing, this is not real life, this is just test taking tips. On the NBME or STEP, if they ever give you like a specific disease that their parents had, like Alzheimer's disease in his father, even if it says Alzheimer's disease on both sides of the family, I would say probably like 99 times out of 100, the correct answer is not going to be Alzheimer's disease in the patient. Now that's different with Huntington's or something like that, or frontotemporal dementia or something like that. But they won't come right out and say that they have Huntington's or they have frontotemporal dementia. They'll kind of indirectly describe it. Well, I had a father who died of a mental disorder, or they'll be adopted. And so they don't know their family history. So that's a different story. But if they come right out and are like, oh yeah, father has Alzheimer's, or kind of like the question with the little kid, with the imaginary friend, father has schizophrenia or something, 99 out of 100, it's not going to be the whatever the father has, that's not going to be the right answer. Okay, and so with this one, this is where it becomes, so most of the time you don't have to be able to count up the different things, like with mania and stuff, you don't really necessarily have to be able to count up all the different dig fast things or whatever. You don't probably even need to, I mean, if you want to commit that to memory, that's fine, the dig fast acronym, but I would recommend committing to memory the SIGI caps. So that stands for sleep disturbances, loss of interest, guilt, hopelessness, worthlessness, decreased energy, decreased concentration, changes in appetite or weight, psychomotor slowing or agitation, and then suicidal ideation. So if they have depressed mood plus 4 or more of those, and they qualify for a diagnosis of depression, I would recommend committing that one to memory because that will come in useful on exams. The different types of depressions are kind of hard to differentiate from. So if we count up on this one, he, let's see, he has little energy, changes in sleep, decreased concentration, slowed speech, psychomotor slowing. So, and then we didn't specifically ask about a depressed mood, but that would certainly probably be the next question in the conversation. So, any questions on this one? I have a few more questions about different types of dementia, so, okay. Oops, what have I done? Oh, go back. So that previous one was major depressive disorder. So he had pseudo dementia. That was the correct answer. Oh, and one other thing on the previous one, the fact that he was still functional, he wasn't like saying, oh, I've forgotten to pay bills and I can't take care of myself and I left the stove on and nearly burned the house down. That's also speaking to the fact that it's either depression or normal aging. Because with dementia, they're, one of the defining characteristics is that activities of daily living are going to be inhibited. All right, give you a few more seconds on this one. Okay. All right, so another really difficult one. So you all correctly identified that the dementia associated with Parkinson's disease is dementia with Lewy bodies. However, is this patient exhibiting any signs of dementia? Obviously, that's a leading question. So the answer is no, he's not. So he's having hallucinations, visual hallucinations. He has some decreased energy, some things like that. Could possibly be depressed, but what's most prominent is his Parkinsonian symptoms. And it says, it makes a point to say he's not forgetful and he's still, he doesn't have any problems with activities of daily living. So this one is actually going to be just Parkinson's disease. So that's another thing that's kind of difficult when you're talking about the dementias to tease out, because not only do you have to determine whether this patient is just normal aging or whether they have some form of dementia, then you have to say, okay, well, is this actually dementia, or is it secondary to depression? So that would make it pseudo dementia, or is this secondary to a medical condition, or does this patient even have dementia at all, and is it just a medical condition? So in this case, it's Parkinson's disease because he doesn't have the dementia aspects of forgetfulness and impaired ADLs, activities of daily living. As soon as he started having those types of things, then he would qualify for a diagnosis of dementia with Lewy bodies. But it isn't uncommon. Visual hallucinations can occur with Parkinson's. And in addition, the medications used to treat Parkinson's can also cause visual hallucinations, sometimes auditory, but primarily visual. So things like pramipexole, ropinirole, which, by the way, you may get a question on step 1 or the NBME. Ropinirole can also be used to treat restless leg syndrome. It's a dopamine agonist. That's just a side note. But yeah, so this guy's Parkinson's. Let's see, was there anything else I wanted to say? And dopamine agonists, so like pramipexole, ropinirole, amantadine, those types of things are more likely to cause the visual hallucinations than are just levodopa, although those levodopa can also cause it too if it's at high enough a dose. Any questions on this one? No? Okay. By the way, the MMSE score, so generally 23 or up is considered normal. Just FYI. I'll give you a few more seconds on this one. Okay, so with this one, yes, y'all did really good on this one. So getting lost in familiar territory, that's concerning for Alzheimer's disease. They have visual spatial difficulties. Word finding difficulty, we call that agnosia. That's common to some extent as you age, also if you're stressed, depressed. Sleep disturbance, that occurs as you get older, you get less sleep. You go to sleep earlier, you wake up earlier, you also have decreased REM time. Awareness of forgetfulness, that's a good prognostic feature. As I said, the MMSE score above 23 is generally considered normal, although you have to take into consideration education of the patient and interpreting those scores. If this patient is really educated, 25 may actually be concerning. Yep, okay, yeah, good job. Any questions on this one? So I do want to take just a quick moment on this one, and I think this is the last side note. No, I'll have a few other side notes on a few other questions, but on this one, so the different types of dementia, I just want to talk about them really quickly. Won't go into a lot of detail, but just enough, and that's all that you'll really need, is just enough to be able to differentiate the different types on an exam, whether it's the MBME or step 1. So Alzheimer's is kind of more of a, as far as test taking purposes, there's technically some criteria out there, and if you meet it, then you qualify. But for test taking purposes, it's kind of a dementia diagnosis of exclusion. You do have the visual spatial, like the disorientation type stuff like this lady had. Early on, though, the most prominent thing is just kind of an insidious onset of memory difficulty. Late in the disease process, you can get some personality changes. But yeah, so vascular dementia, what's the main kind of, oh, and then also, of course, on imaging, you can see some global atrophy with Alzheimer's. With vascular dementia, what's the kind of defining characteristic of that one? Did y'all have a lecture on this one? On dementias? Yeah, stepwise decline. Y'all had a lecture on dementias, right?
Yeah.
Okay, cool. Okay, so yeah, so stepwise decline. Also, you'll see like infarcts or like deep white matter changes on imaging. And also a lot of times you'll have some focal neurologic deficits as well, because basically they're just having small strokes over and over, right? So this patient is definitely at, not this patient, never mind, but you could have a patient who's at risk for those things, diabetes, hypertension, that could also be clues there. Okay, so frontotemporal dementia, what's the kind of defining characteristic of that one?
Is that like personality changes?
Yeah, our personality changes occur early on. So disinhibition, apathy, impulsivity, typical onset 50s or 60s, years of age. Also, I don't know if they mentioned this, but hyperorality is something that they might also use to cue it. So they might start smoking more cigarettes. They might start eating their food weird, or take a liking to only a particular type of food, or like to put things in their mouth. I'm not exactly sure why that happens, but that could be a clue on an exam. And then obviously frontotemporal atrophy on imaging. Okay, dementia with Lewy bodies. What are some defining characteristics of that one? Hallucinations, yes. So the visual hallucinations. What else?
Would it be the Parkinsonian symptoms?
Yes, yep. Parkinson symptoms. And then one other thing. So fluctuating cognition. So this one is one that could kind of be confused with delirium if you're not careful. So they'll be better oriented and have better memory at times, and then at other times it'll get worse. So fluctuating cognition, Parkinson's symptoms, hallucinations, particularly visual hallucinations. And another one could also be REM sleep behavior disorders. So remember I said last time that when people start having, particularly like older men, if they start having REM sleep behavior disorders, so like they're running around acting out dreams when they should have atonia, that can be an early indicator of something like Parkinson's or dementia with Lewy bodies. Normal pressure hydrocephalus. What about this one? There's like 3 words for that describe that one.
Wet, wacky, and wild, or
Yes.
wobbly.
Yes, wet, wacky, wobbly. So wet, urinary incontinence, wacky, the dementia part, and then wobbly, the ataxia. And why is, and so on imaging, you can see some dilated ventricles. And why is this one an important one?
It's reversible?
Yes, it's one of the few dementias that's reversible. Pseudodementia being another one that's reversible, dementia caused by depression. But yes, normal pressure hydrocephalus is reversible. And the last one, so a prion disease like Creutzfeldt-Jakob disease, what are we looking for here?
Is that rapid decline in cognitive function?
Yeah. Yes, so rapid progression, a lot of times within a year, from symptom onset to death. You can have some myoclonus, like spastic jerking, seizures. Those are all things that you'll see with it. And then what do you see on an EKG? I mean, not EKG, EEG with CJD, Creutzfeldt-Jakob disease. Yes, so you'll see slowing of all waves with periodic sharp wave spikes. Yeah, exactly. Okay. Yep. All right. Move on to the next one. Any questions about dementias? Oh, sorry, did I not release the poll on this one? Oh, sorry. There we go. Thank you. Okay, give you a few more seconds on this one. Okay. Alrighty. So y'all did pretty well on this one. So what is going on with this patient? What's his diagnosis? Anybody? About 50% of y'all got it right. Anxiety, perhaps secondary to PTSD with this patient. So, so the reason that I put this one up here is because generally on exam questions for MBME and STEP, they'll kind of give you a flavor of what they want you to answer in the question. So you don't necessarily need to memorize all the diagnostic criteria because they'll kind of hand it to you with certain keywords, what they're trying to tell you. Except the one thing that I would say is an exception are the different types of depressions, but then also with PTSD, sometimes they'll try to slip it to you without directly handing it to you, if that makes sense. They'll be very discreet with it. So PTSD versus acute stress, well, technically, I guess if they don't give you a timeline, you can't know for sure. I think this one said that his 2 months ago, he had the MI. So could be acute stress, could be PTSD, I suppose. We don't know for sure in this one, but in either way, in either case, similar course of treatment. No, you're fine, you're good. But so PTSD for diagnosis, you need the exposure to a life-threatening event. They either happened to you or someone close to you. It had to be witnessed. So then you'll have intrusive, invasive memories. So that can be nightmares, flashbacks, and then you have to have avoidance of reminders, possibly some dissociation or emotional detachment, and hypervigilance secondary to anxiety and hypervigilance, irritability, that sort of thing. So with this patient, you kind of have to tease it out. So he had a life-threatening event. He had the cardiac arrest. And so it doesn't directly tell you, but it says that he often wakes up startled and diaphoretic. So that could be indicative of what? Could be hypervigilance, could be panic attacks, could be nightmares. Yeah. So yeah. So so we have perhaps some intrusive memories there. Then it says that he wants to take things slow. So he's asking his partner to cover upcoming court appearances. Court was where he had his cardiac arrest. So that could be considered a what type of symptom? Avoidance. Yep, exactly. So that could be considered an avoidance symptom. He's avoiding the area where it originally happened. He's been sleeping restlessly, could be indicative of the hypervigilance that Stephen said. Not necessarily, I don't really see any evidence of, it was said he's been very stressed too, but, I don't see any evidence of dissociation here, I don't think. But in any case, so we kind of have enough to guess that it is probably PTSD or acute stress. So with either of those, SSRI, SNRI can be used. Also, CBT is a really, really big part of that, especially for acute stress. That the earlier that the symptom, like the earlier it is in the course of symptoms for acute stress and for PTSD, the more important it is to get the CBT because it prevents it from becoming as long-standing. So, okay, that was the point of this question, is to show you how they like to be tricky and mean. All right, any questions on that one? Okay, a few more seconds. Okay, so this one was a difficult one. So what does this patient have?
Is it social anxiety?
Yes, social anxiety disorder, specifically what type? Performance only, because she doesn't really indicate that she's having any problems socializing, right? She has friends, she has a boyfriend or had a boyfriend, you know, that sort of stuff. It's really all she's complaining about is the presentations, right? So if it was just generalized social anxiety, we could treat that with an SSRI, that would be first line. But since it's performance only, what do we opt to typically treat those with? You can treat them with SSRI, SNRI, but typically if they don't have any problems anywhere else, that's not something that you're going to want to do. Yeah, so a beta blocker is one thing you can use. Also a benzodiazepine. Either of those would be appropriate. So in the situations in which you would use a benzodiazepine could be if it's like I have a huge presentation or I have a huge whatever in 2 days and I need it immediately, because the best thing is CBT, but obviously in 2 days or whatever you can't necessarily CBT won't be effective that quickly. So, but you don't want to give a benzo for a couple reasons. The first big reason you wouldn't want to give a benzo is if whatever they're doing, like a presentation, an intellectual presentation, if it requires that they need to be cognitively sharp, you don't want to give them a benzo that could potentially blunt their cognitive thought processes. And secondly, if they have a personal or family history of abuse, like we talked about earlier with the stimulants. So she drinks alcohol and uses marijuana socially. If she just drinks the alcohol, maybe, maybe not. But the fact that she uses marijuana, mostly illicit substance, that's considered drug abuse. So we wouldn't want to give her the benzo in this instance. We would want to give her a propranolol, a beta blocker. And another indication to give a beta blocker over like a benzo or whatever would be if primarily the problem is symptoms. So she goes into a lot of detail saying about how her heart begins racing, her voice cracks, she turns bright red. So this is a very predominantly like symptom, like physical symptom heavy case of performance only social anxiety disorder. And propranolol is very good with treating the symptoms. May not do as much for the anxiety, but it does a lot for the symptoms. So that's another reason why we'd want to give that to her in this instance. There are two things. What could she possibly have? One big thing that she could possibly have that would be a contraindication to giving a beta blocker for the sake of the problem. In real life, it's different, but for the sake of the problem, what kind of medical condition could she have? Asthma, yep. So if she has asthma, you don't want to give a beta blocker because beta 2, those are going to be the things that dilate your bronchioles. So if we inhibit those, then they're going to have unopposed constriction, and their inhalers are less likely to be effective because we're blocking all the beta 2 receptors. So the inhaler can't get there. So yeah, so asthma would be a contraindication for the sake of a problem to beta blockers, and also if they had like severely like low blood pressure or something, that could also be another reason not to give it to them. Okay, any questions on this one? All right. Oh, go back. Okay. A few more seconds. Oh, never mind. We don't need them. Everybody's answered. Okay, great job. Okay, so y'all are really good on this one. So what does she have?
Postpartum depression.
Postpartum depression, right? So there's three kind of issues on the psychiatric scale that you have to differentiate between when you're talking about depression in a woman after she's given birth to a baby. So the first one, the kind of like least dangerous one is postpartum blues, the baby blues. Like 80% of women will get that. It's very common. That can have some depressive symptoms, some irritability, some mood swings, yada, yada, yada. Typically not really much functional impairment, no like suicidal ideation, infant homicide ideation, nothing like that. But the key thing is that if it lasts less than, though that should resolve within 14 days. If it lasts less than 2 weeks, so if she comes in at day 7, day 8, day 11, and she's having some irritability, depressive symptoms, more than likely it's going to be baby blues. However, as soon as it passes that 2-week point, it's, 3 weeks in, it's day 15, it's whatever, then that's when you diagnose postpartum depression. If it lasts more than 2 weeks, they automatically get that diagnosis. Another way you can go through is to look and see the SIGI caps. But really the time period is what they're going to test you on here. Less than 2 weeks, baby blues, more than 2 weeks, depression. And then obviously the biggest, baddest one is going to be postpartum psychosis. And that one, pretty uncommon, about like 0.1, 0.2% of new mothers. But that one is particularly dangerous. I mean, they're going to have psychotic symptoms, things like that. It can occur, variable onset can occur within days to weeks. But why is that one particularly dangerous?
They have thoughts of hurting the baby.
Yeah. The risk of infanticide, I guess would be the word. But yes, they could hurt the baby. Yes. So part of any kind of postpartum maternal screening should include questions about, do you want to hurt yourself? Do you want to hurt the baby? Or have you had thoughts about hurting yourself, thoughts of hurting the baby? So as far as treatment for baby blues, it's just reassurance and follow-up. For postpartum depression, SSRI or psychotherapy, depending on what they want. Support group is probably not really ever going to be the right answer for a test question, because it's not considered a definitive therapy for anything. Although it could definitely be helpful for her, a helpful adjunct. Psychiatric hospitalization, that would be primarily indicated in which of those 3 disorders?
Psychosis.
Yeah, the psychosis, if they have thoughts of hurting the baby. Parenting skills training, that's going to be more for something like ODD, or that can be part of the treatment. Also, that's oppositional defiant disorder, or also for something like some kind of parent-child relational problems early in life, like less than 4 years of age. Okay. Some other things, like you can have some OCD onset postpartum, things like that, but that would be fairly obvious. If it meets criteria for OCD, like with obsessions and compulsions, it's not going to qualify for baby blues or anything like that. And then as far as what to treat with, what SSRI would we probably want to give a breastfeeding mother? So sertraline is what we're going to want to give, because sertraline has negligible amounts in the breast milk. It's undetectable. So that would be the one you'd want to give to a breastfeeding mom. Okay. Any questions? Okay, a few more seconds. Okay, so y'all did pretty good on this one. So what does this patient have?
Depression.
Yep, depression. So depression, pediatric depression, a lot of times will present with a predominantly irritable mood versus a depressed mood. This is differentiated from normal because of why. Why is this not normal behavior? For the sake of the problem.
She was previously doing well.
Yep, exactly. Previously doing well, now she's failing. So that's an indication that this is some kind of pathology. And so depression in this case, you can count up the SIGI caps on this one as well. And so the second part of this question I wanted to get at is, what is the treatment of choice, the SSRI of choice for pediatric depression? Or I guess anxiety as well. So it's fluoxetine. Fluoxetine is going to be the treatment of choice in children. It has the most studies substantiating it. You can use others if fluoxetine fails. But what do you want to be sure to monitor patients for if you give them fluoxetine or any SSRI, particularly adolescents and children? What do you want to monitor for?
The suicide.
Yep, suicide. There's an increased risk of suicide in certain pediatric patients treated with SSRIs. Correct. Okay. A few other things about SSRIs that I wanted to mention. So not technically an SSRI, but buspirone, that'll come up as an answer choice for a lot of things. Buspirone, pretty much for the sake of your problems, has one indication and one indication only. What indication would buspirone be? Answer your question in just a second, Harrison. Yes, generalized anxiety disorder is really the only indication for buspirone as far as the MBME and step 1 goes. Any other medication, any other condition, whether it's, OCD or another anxiety disorder or depression, buspirone is really not going to be effective. And then bupropion is really not going to be used for anxiety. It's mainly used for depression with some of the, like a third line therapy for ADHD, that sort of stuff that we talked about. Is there an age limit for MDD? You mean like a lower age limit or an upper age limit? I'm assuming you mean lower. Lower, okay. No, I don't think so. If you mean like with like how ADHD and intermittent explosive disorder, you can't diagnose it in really young children because it's consistent with normal development. I'm not aware of one, although I would say would probably be less likely to be diagnosed in a young child. But I don't think that there is, not that I'm aware of. Let's see, what else? Oh, talking about SSRIs, so bupropion, like let's say I had a patient who had depression or whatever, but she had a history of bulimia. Would I want to prescribe bupropion in that instance?
No.
No, why not?
It lowers the seizure threshold.
Exactly. Bupropion lowers the seizure threshold. All SSRIs do a little bit, but particularly bupropion and bulimia, she could have electrolyte derangements, which would cause her to be at increased risk for seizures. So as far as SNRIs over SSRIs, SNRIs would carry more of a activating effect, so that could be an indication for them. It would more be an indication not to use them, which would be if they're already having like insomnia or something like that, you would not want to use an SNRI. Probably initially, you'd probably want to go with an SSRI. Same thing for bupropion. So that sort of thing, if they're like not eating, having trouble sleeping, losing weight, probably don't want to go with something that's activating. Also, if they are like hypertensive or have some sort of heart condition, probably don't want to go with an SNRI right off the bat because you would stress the heart, and you could also, it'll increase blood pressure. It has the potential to do that because of the norepinephrine part. So if a patient is already hypertensive, probably don't want to give it to them. can't think of anything else just right off the bat for that one. So yeah, I would say it's more of a equal to, but some instances SNRIs would be contraindicated versus an SSRI. What's the problem with citalopram and escitalopram? What's the problem there with those? What side effect do they have? So they can prolong the QT, those two can. All SSRIs, I guess, potentially could, but particularly citalopram and escitalopram can prolong the QT. So if you ever have a patient who has like some kind of heart, abnormal EKG or something, probably would want to go with an SSRI other than citalopram, escitalopram. Oh, and then one last thing. So let's say I have a patient who comes in and a male patient, and for the past 6 months, he has not been able to, for the past 6 months, let's say he's had premature ejaculation, like within a minute of intercourse. So what would be a potential treatment for this patient, assuming that we've ruled out any kind of medical causes or whatever? What would we want to treat him with? Yeah, we could treat him with an SSRI. Probably paroxetine is one that they like to use for that, but I think any SSRI would suffice. So because SSRIs have the additional side effect of not only like decreasing libido, but also prolonging time to ejaculation. So you're basically giving him the SSRI for the side effect of prolonged time to ejaculation to help his premature ejaculation. So that could be like an off-label indication for use. I had a few questions on those. So, okay, or a question on that. Okay, alrighty. All right, yeah, I think that's all. There you go. A few more seconds. Okay. Alrighty. So yeah, y'all did really good on this one. So why do we want to give this gentleman bupropion? Anybody? Y'all almost all 60% of y'all picked it. Nobody has a reason for picking it? Yeah, exactly. So bupropion, because of the norepinephrine, dopamine norepinephrine, has activating effects. So particularly a patient who has low energy, who is sleeping too much, who's overeating, who's gaining weight, bupropion is a good thing to give them because it will help with all those. It'll be activating so they eat less, they're less sedated, I guess, less tired. Yes, weight loss, all that. Yes, exactly. So mirtazapine, several of y'all picked that one. Mirtazapine, what effect does that have? Well, what's the mechanism of action and what effect does it have? Yeah, so it's the opposite. Mirtazapine is sedating, stimulates hunger, weight gain. Yeah, and so what's the mechanism of action of mirtazapine? So it does have some of that. So it does hit a few receptors, but particularly the sedating effects and stuff are mediated, yes, by the serotonin receptors. Yeah, it's a serotonin modulator. Yes, so back to somebody's question earlier about the serotonin receptors and the like sedating metabolic effects. So mirtazapine would be good to give to someone who has insomnia, they're not eating, they're losing weight. So the opposite of what this guy's problem is. That'd be a good thing to give to them. I think I was also going to say something else, but now I don't remember. So, okay. Oh, yes. So, and then someone, I think maybe Stephen has said, so if we want to supplement a patient who is already on an SSRI, we typically want to supplement them with something that has a different mechanism of action to avoid what? Precipitating what? Why would you not want to put someone on 2 SSRI? Yeah, serotonin syndrome, exactly. So that would mark out citalopram, buspirone. We said that's only indicated for generalized anxiety disorder. No one picked the antipsychotic. That's great. Or the stimulant. Yeah, stimulants are only indicated for ADHD. Never be tempted to pick those for depression or anything like that. And then phenelzine is an MAOI. So that's a lower level. That's a lower tier, like second or third line, probably third line treatment. And also, why would we not want to give this patient an MAOI? Kind of for the same reason we wouldn't want to give 2 SSRIs, because we wouldn't want to precipitate serotonin syndrome again, right? We have to have that 2-week washout period. Okay, any questions on that one? Oh, also bupropion, there's 2 other beneficial things that bupropion has. What is another indication for bupropion besides activating effects associated with depression? Smoking cessation, good. And it also has no sexual side effects. So that's another thing, benefit of bupropion. Okay. Almost done. A few more seconds here. Okay. Good, y'all did really good on this one. So what happened to her?
The antidepressant.
Antidepressant.
Yeah. Yes, exactly. Antidepressant-induced mania or hypomania. Maybe hypomania for her, because she's not really exhibiting any kind of like pure dysfunction or whatever, but could be mania. We would have to get more information, but it doesn't matter. Either way, yes, it is antidepressant-induced, and so that's something that you'll see if you do give them an antidepressant, because normally an SSRI or some kind of antidepressant takes about how long to reach its full effect?
4 to 6 weeks.
Yeah, takes multiple weeks. And on top of that, in the first couple of weeks after starting it, you're actually more likely to have increased anxiety, headache, nausea, vomiting, like you're not going to feel great. So this is a very atypical response to an SSRI to after 2 days feel great after you were depressed. And so, so the first step is always going to be to discontinue it. So if the golden rule or a golden rule of medicine is that if a medication is offending a patient, if it is causing some kind of symptoms or syndrome or whatever, unless this patient needs this medication to stay alive and there's no other options, the first step is always to discontinue it. And then you add on medications as needed to stabilize. So after we discontinued it, if she didn't return to normal and baseline, then we might start adding lithium or valproate, and she may need those anyhow, if she's truly on the like bipolar spectrum. So there would never, as far as checking serum antidepressant level, that's never indicated. The only time you check levels are for like lithium, valproate, those types of things. Antidepressants, you don't ever need to check levels on those. So, and any kind of antidepressant, anti-anxiety can cause it. So not just SSRIs, it can be TCAs, it can be bupropion, it could be anything can induce the hypomania, mania. Okay, any questions? Okay, a few more seconds. Okay, great. Yeah, really good. So this individual is having a hypertensive crisis. She is, did I tell you? She's being treated with phenelzine, which is an MAOI. So with phenelzine, it's important to differentiate. We talked about serotonin syndrome, which is where you would probably see the hyperreflexia, the myoclonus, right, as answer choices here. Muscle rigidity would be specific to NMS, neuroleptic malignant syndrome, with risperidone, which wouldn't necessarily present like this. And sometimes they can be hard to tell apart. So you really have to rely on the history then with these. So with this one, so the fact that they're telling you that she had a gourmet meal with heavy sauces and wine, they're kind of handing you that clue that it's a hypertensive crisis. So as far as why it happens, why would someone taking an MAOI have a hypertensive crisis after eating cheeses, wines, cured meats, overripe fruits, fermented products? Yes, tyramine. So tyramine is a sympathomimetic and is normally broken down by the monoamine oxidase. But when monoamine oxidase is inhibited, the tyramine is allowed to exert systemic effects, and it actually induces the release of more sympathomimetics like adrenaline so epinephrine or norepinephrine. Those are, tyramine has increased concentration in cured, aged, fermented type things. Yes, I think that's it. Hypotension, that answer choice would have been for MAOIs just in general can cause hypotension because they're kind of a dirty drug. Okay, any questions? Okay, a few more seconds. Okay. All right. So this one was a really difficult one. One of the adjustment disorder will pop up not only as a correct answer, at least probably once on your test, but it'll also pop up a lot of times as an incorrect answer. So it's the depressive symptoms, like the, what's it called? The spectrum of depressive disorders are really difficult to differentiate. So it's really important with those that you do know the like specific criteria. Like I would recommend memorizing SIGI caps and also the timeline for different ones. So, okay, so if we're talking here about this patient, so another thing is that, so adjustment disorder is kind of like a weak diagnosis. If there's any other possible diagnosis that you can give a person that they meet the criteria for, that trumps the diagnosis of adjustment disorder. So it's more of a diagnosis of exclusion kind of. And on top of that, shoot, what was I gonna say? Oh, yeah, so you can count up the symptoms. So in this case, so depressed mood, he has, and so if we count up the symptoms, then he has sleep disturbances, poor energy, poor concentration, guilty thoughts, I'm bringing everyone down, appetite disturbances with weight loss. So he has at least 5. So all he needs is 4. So he meets the criteria for depression. And it's been, so the thing about psychiatry, one of the kind of cardinal rules is, I'm saying there's a lot of cardinal rules, but one of the cardinal rules is that stress can exacerbate underlying conditions or induce conditions. So just because there was a clear trigger, the death of his brother, that doesn't mean that it's automatically adjustment. It can be severe enough to trigger a major depressive episode. So if he meets the criteria for it, 2 weeks or more of depressed mood plus 4 more SIGI caps, then you give him the diagnosis of major depression. So this person has major depressive disorder. As far as acute stress disorder, he's not really, so first off, his brother died 3 months ago. So that would push it over, assuming his symptoms have been present since his brother died, that would push it over from acute stress to PTSD, but he's not displaying the avoidance, the intrusive memories, reliving it. I guess you could argue maybe some hypervigilance, but with the anxiety and stuff, but not really PTSD type symptoms. As far as a normal grief reaction, so normal grief, it should be all focused on the person who is deceased. So your thoughts should be about them. If there's suicidal ideation, it's suicidal ideation about wanting to be with them. That's why you want to be dead, is because you want to be with them. It kind of seems to come in waves, and it should be intermixed with some like positive-ish nostalgic type memories as well. Yeah, so and it's less of a functional decline compared to this. It's affecting his work. He's losing weight. You shouldn't lose weight with a normal grief reaction. So, okay. And then no one picked the persistent complex. So, okay. Let's see. Oh, and one other thing I want to mention. So some other clues that it's depression, besides just, if you count it up, that's enough to give you the diagnosis, pick your answer and move on. But some other clues, if you're still not convinced, is so the early morning awakenings, we call that terminal insomnia, and that's characteristic of depression, very characteristic of it. And then also the fact that his mood symptoms and anxiety seems to be worse in the morning and then kind of get a little bit better throughout the day, also characteristic of depression. So any questions on that one? Okay, a few more seconds. Okay. So y'all did really well on this one. So what does this patient have? What's his diagnosis? No diagnosis for him? So I'll give you answer choices. Does he have major depressive disorder? Does he have adjustment disorder? Does he have persistent depressive disorder? Does he have a personality disorder?
Adjustment disorder.
Adjustment disorder. Yes, there we go. So yeah, so he, oh, sorry, I didn't see breakup sadness. Yeah, so that would be an adjustment disorder. Yeah. So adjustment disorder, we just said it doesn't meet the criteria for anything else. It occurs, it has to start within 3 months of a clear stressor. So there has to be a clear stressor. If there's not a stressor, can't diagnose it. And it doesn't last for more than 6 months. Okay. So he does meet that. And then another thing, if they want you to go with adjustment disorder, a lot of times they'll put something in the question saying that like, indicating that he's still functional, because with adjustment disorder, they're typically still mostly functional. Like they may have a few dysfunctional things, like the fact that, you know, he's like not interested in dating or whatever right now. You could see that as maybe like a dysfunctional in a sense, but he continues to meet his deadlines and fulfill all his professional responsibilities. That's the question writer's cue to you that he's still functional. So it's not anything more severe than adjustment disorder, because in order to diagnose anything else, he needs severe functional impairment, and his is only mild functional impairment with distress. So let's see, what else did I want to say about oh, and so for as far as treatment, so the treatment for adjustment disorder is only psychotherapy. There are no drugs for adjustment disorder, no SSRIs, no anything like that. It's only psychotherapy. So counseling, that sort of thing. Yeah, so that's why that's the correct answer choice there. As far as the different spectrum, and the psychotherapy will focus on like coping skills, things like that, thought reframing. So as far as the spectrum of different depressive disorders, so major depressive disorder, we talked about 2 weeks or more with depressed mood plus 4 or more SIGI caps. Persistent depressive disorder has to have the 2-year thing. A lot of times they'll indicate to you that it's been going on for 3 or 4 years or something like that, or, you know, since their 20s or something. So that's, and it's maybe not as severe as depression, maybe only like 2 or 3 symptoms instead of 4 SIGI caps. We talked about adjustment disorder, and adjustment disorder doesn't necessarily have to be with depressed mood. It can be with like behavioral disturbances, irritability, that sort of thing. But they're always going to retain some function, maybe decrease function, but they'll still have some function, and they'll indicate that to you in the problem. And then a normal stress response, they'll make a point to say like they're still carrying on normally with everything. Like for this patient to have a normal stress response, he would have to still be out dating, not over dating, like, you know, like having one night stands and stuff, but still out dating, no decreased motivation at work. He just feels maybe a little irritable, stressed, that sort of thing. So absolutely no functional impairment is a normal stress response, according to the questions. Okay. And one of the things, cyclothymic disorder can be very easy to confuse with borderline personality disorder. The way you differentiate that is that cyclothymic disorder, they're like mini depressive episodes and like mini hypomanic episodes. Again, they don't meet full criteria for either one, but those episodes that they have are not going to seem to be precipitated by any kind of life event, and they'll just last a few days, maybe weeks, but mostly a few days. Whereas with bipolar, borderline personality disorder, they're going to be precipitated by life events, by a breakup, by, I think that, you know, my husband's cheating on me, by, you know, whatever it may be. borderline has fluctuations in response to things that happen to them, whereas with cyclothymic, it's independent of that. They're just sad for no reason now. Now they're happy for no reason. So, okay. Any questions on that one? All right, last problem. The last melon. All right, a few more seconds here. Okay. Alrighty, so this one was difficult. So, okay, so this gentleman has major depression with psychotic features. So it can be difficult to differentiate when there's psychotic features involved. It can be difficult to pinpoint what disorder they have. So to see if it's major depression, first you want to see, the first thing that you want to do when you're looking at this problem, you want to see with the psychotic features, are there any mood symptoms? So if there's features of depression or a manic episode, then you want to look at the length of time here, which precedes the other. So with this one, his delusion about he has brain cancer and he thinks it's like a punishment for the sins that he committed as a child, that started over the past month, right? However, it says that he's had little energy and appetite for the past 3 months. So those are depressive symptoms. Wife died 6 months ago. He's lost weight since then. And it goes on to describe a whole bunch of other depressive symptoms. So his mood symptoms, his depression precedes his psychotic features. So that is suggestive of major depression with psychotic features. I should have given you answer choices for psychiatric disorders like schizoaffective and schizophrenia, which I didn't, but oh well. But that would also rule out those disorders, right? Same thing with a manic episode. If he was having a manic episode and having some kind of psychotic features, like he was, hearing the voice of God or getting messages from the cosmos or whatever, you want to look and see which came first. Was it his manic episode symptoms or was it his psychotic features? So if the psychotic symptoms, which psychotic can be delusions, hallucinations, visual or auditory. So if those are occurring only within the context of mood symptoms, it's mood symptom X with psychotic features. So major depression, bipolar disorder, manic episode, whatever with psychotic features. If they have schizoaffective disorder, they'll make a point to indicate a period of time when there was no mood symptoms, but they did have psychotic features. So they may present like this, but then they'll say there was, for the patient has reported increased mood and no depression for the past 5 weeks, but continues to hear, whomever talking to him or whatever continues to believe that there's something wrong with his brain or whatever, then that would be indicative of schizoaffective. But they'll make a point to say that there's a period of time with no mood symptoms when they still had psychotic features in order to get schizoaffective. And in schizophrenia, you wouldn't really have any prominent mood features at all. Another way that you can differentiate between is it mood disorder with psychotic features or schizoaffective is, are the psychotic features, like the delusions, hallucinations, are they mood congruent? Mood congruent means that if I'm depressed and having a depressive episode, my delusions and hallucinations are going to be sad or scary or whatever. So I'm gonna, hear demons talking to me, or I'm going to think that I'm dying, or there's something wrong with the brain, or I'm paying for some kind of sin, right? If I'm having a manic episode, mood congruent would be, someone's whispering to me that, I'm God's chosen one, or I believe that I can heal people, or whatever it may be, right? Mood incongruent would be suggestive of a psychotic disorder. So if I have mood symptoms, but my psychotic features are that I think that someone planted a chip in my head, or I'm thought broadcasting, or, something like that, or think that someone's watching me, but like, not necessarily in like a negative way. I just think that someone's watching me, so more paranoid, whatever. Mood incongruent is going to be more suggestive of a psychotic feature, not a primary mood disorder. Delusional disorder, so that cannot have anything else wrong with them. They have to be completely functioning otherwise. So no mood symptoms, no other psychotic symptoms, so no hallucinations, anything like that. It's really rare, and all that they'll think, aside from the impact of their delusion, they're completely perfectly normal with no symptoms. So in order for this person to look like a delusional disorder, he would not have any of those depressive symptoms, and it would just be like, I think there's something wrong with my brain. And so even that delusion would probably be more of an illness anxiety disorder. So let's say they had a delusion like, I don't know, I think I have a third arm or something like that. Then that could be a somatic type of delusional disorder, as long as there's nothing else going on, like they have no hallucinations, anything like that. Everything else is, they're completely functional besides the fact that they think they have a third arm. Persistent complex bereavement disorder. So that one, they don't meet the timeline criteria because you need 12 months or severe functional impairment. But if you meet the criteria for depression, then that is diagnosed instead. And also with persistent complex bereavement disorder, psychotic features would by definition make a grief reaction a persistent complex bereavement, but it's all focused on the deceased. In order for it to be any kind of grief or complicated grief, which is the same thing as persistent complex bereavement disorder, or even a normal grief reaction, it has to all be focused on the deceased. So this is focused on him, his brain, he's paying for his sins. Now if it was, I think that, like, if it was guilt about, that maybe he wasn't with his wife when she died, or he thinks he treated her poorly or something, focused on her, not him, or if he's hearing her voice, hallucinating that he's hearing her voice, something like that, then that would be more geared toward a bereavement, some kind of grief disorder, right? But if that's how you differentiate grief from depression, is it focused on the person who died, then it's grief. If it's more generalized and not necessarily focused on them, then it's depression. Depression can be triggered by death, as with it can be triggered by a lot of different things. Okay. And so as far as how to treat major depression with psychotic features, it's a really severe form. So if you can, you want to treat it with an antidepressant and antipsychotic, but severe cases, particularly if he's not eating, or if it's refractory, then electroconvulsive therapy, ECT, would be the choice. So that's all my questions, but I do have a few just last things that I didn't have a question on, but I just want to throw out there real quick, things that I didn't know before the test that I thought I needed to know. So the first one is, how do you treat, what's the treatment for nightmares? What drug can you give to treat that?
Prazosin.
Yeah, prazosin. Yep. Prazosin can treat nightmares, so particularly in PTSD, you'll want to give it then. Let's see, another thing, if I have a patient who's coming in for an evaluation of possible dementia or something like that, what is kind of, if they ask you, like what you want to do next, the patient's not depressed, you've already screened for depression, things like that. What might be a test that you want to do, that you want to rule out before you really chase down some kind of dementia diagnosis, especially if you're kind of on the fence? What's something you want to rule out? So, okay, so stroke would kind of go along with the vascular dementia, but so I said if you ruled out depression, you would want to rule out depression. You're right, but so something else you want to rule out is a hearing impairment. So hearing, no, you're good. So hearing loss can mimic dementia, because you'll ask people to repeat things. They think you've forgotten when really you just didn't hear them. You give incorrect responses when really it's just you didn't hear them, right? Same thing goes for the opposite end of the spectrum with little kids when you're worried about like an autism or language disorder or something like that. Screening, a hearing screen is one of the first things you want to do to rule out, because that can mimic lots of different disorders. Also catatonia. So that is, what are some, I'll just tell you. So some symptoms of catatonia. So you have like waxy posturing. So like it can be kind of hard to move, but once you move the arm into a position or something, it stays there in an unnatural opposing gravity type situation. Waxy flexibility, that was the name of it. Posturing or waxy flexibility. You can also have them echolalia. So they like repeat words over, like you say a word to them, like get on the bed, and they say bed, 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 bed. They can also repeat motions over and over. And so anyways, and a lot of times it'll occur in the context of an existing psychiatric disorder. And how do you treat catatonia? What drug? Ironically, you treat it with a benzo. So it seems kind of counterintuitive, but you treat catatonia with a benzo. Let's see. Oh, one other thing. So with with schizophrenia, one of the common treatments that, like one of the psychotherapies that, or one of the therapies that you want to add to the regimen, family therapy is important with schizophrenia. A well-functioning family that's aware of the illness and able to appropriately treat the patient decreases the risk of relapse in a patient. So family therapy can be an answer for that. And then I think the last, two things, I think. Yeah, two things. The first one is that if someone, you can get antidepressant discontinuation syndrome, which is if you abruptly stop like an SSRI or any other kind of antidepressant, anti-anxiety medication, they get flu-like symptoms in the following days if they've been taking it for a while. So like over the next couple of days all the way up to 2 weeks, if they start having flu-like symptoms, that's indicative of antidepressant discontinuation syndrome. And that can occur with any antidepressant or anti-anxiety medication. And the last thing that I wanted to, last two things. I know I keep adding things, but I swear this is the last two things. So the first is that if a problem tells you that that if they report some kind of finding on physical exam or make a point to point out something physical about a patient, it's significant for the purposes of psychiatry. So if they comment on the patient has a ruddy round face, they're not just saying it for giggles. What are they maybe trying to hint at there? So ruddy round face. What if I said they had central obesity on top of that? So Cushing's disease. So that could be something there that can precipitate some psychotic features, manic episodes, depression. Steroids, as far as drug-induced types of like psychotic or psychiatric mood disorders, steroids are a really commonly offending agent. They may try to be sneaky and say that the patient like went to the hospital with an asthma exacerbation, was started on a new oral medication, and now they're having a manic episode, or now they're having psychotic symptoms, or now they're having a depressive episode. Steroids are a common offending agent for a lot of different things, psychiatric wise. So anyway, so if pay attention to any kind of comments on physical exam findings. Yeah, and then so the last thing I was going to say is that if a patient ever comes in and they're describing like PMS or PMDD, so that's premenstrual, what is it, dysphoric disorder? Anyways, but if they come in with one of those two things, so they describe like cyclic episodes of irritability, whatever, blah, 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 mood swings. So the initial thing you want to do is have them keep like a menstrual diary or something. That's always going to be the first treatment before you start any kind of medication. So because you want to make sure it's not just an exacerbation of something else, underlying symptom. Okay, so that's it. I'm done, I promise. Okay, any questions? Okay, well, I'll stay on in case anybody has a question they want to ask. I know it went over again. I'm really sorry. Y'all are welcome.
Amanda,
Uh-huh.
could you clarify or help me clarify? There's especially one question that I had struggled with in one of the lectures that was talking about basically the two of the answer choices were cyclothymic versus bipolar 2. And it basically had the timeline of cyclothymic. And I actually haven't seen what the answer is yet, but I think somebody had mentioned it was bipolar 2. But and my understanding is basically, is the way to differentiate that, like if it has enough time to be cyclothymic and doesn't specify like how long between the intervals, is it, do you just look to make sure that they have major depressive if it's bipolar 2? Or like, how do you differentiate between them?
Yeah, so all those things would be good. So yeah, so for bipolar 2, you have to have at least one depressive episode. So you would look to make sure that you want to check to see if there's a depressive episode. And a lot of times, even if they don't give you all the symptoms, all the SIGI-CAP stuff, you can just look at level of functional impairment. So did they have, when they describe their low periods, are they, were they not able to go into work and blah, 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 or were they just kind of like a little bit down and distressed? So that would be one thing to look at. Another thing to look at would, like you said, be the timeline. So cyclothymia, I believe, has to go on for 2 years, I think, to get the diagnosis. So you want to make sure that and it has to be pretty much constant cycling. So you want to look at that. And then also you can look at the hypomanic episodes. Hypomanic obviously doesn't meet criteria for mania, but in a patient with cyclothymic disorder, they won't really even meet like a hypomanic criteria. They'll just be like kind of like mildly irritable or like mildly like more productive, if that makes sense. So less functional impairment.
Okay, yeah, no, that makes sense. Thank you.
Yeah, you're welcome. You're welcome.
Awesome. All right. Thank you.
Yeah, no problem. Thanks for coming. Good luck.
Thank you.
Mm-hmm. Let me check the chat. Okay. Alrighty then.